Bismillah ar-Rahman ar-Rahim. Today I would like to present a very important topic in palliative care, which is considered as an emergency situation, which is delirium. Delirium is a common complication near end of life. It tends to affect around 15 to 25% of hospitalized cancer patients, and up to 88% of terminal cancer patients will be affected by delirium. It is very distressing to patient, to the loved ones, to the caregiver, and to the staff. Uh, it may alter our symptom assessment and control. For example, if the patient is in delirium and he has pain at the same time, our judgment on the pain control will be very affected by the delirium status. Uh, it is underdiagnosed, although it is very common and undertreated in the situation of palliative care. In palliative care, this situation constitutes a medical emergency. It is difficult to diagnose because of variability of symptoms and signs. There is fluctuation of the course. There is confusion between other psychiatric problems like depression, dementia, psychosis. So regular screening of our patient on daily basis is very important. Especially this fluctuation of course will be greatly affecting our judgment and diagnosis. Because sometimes the caregiver or the nurse who is attending the patient more frequently will notice that there is change in the status of the patient. But we doctors, when we came to evaluate the patient, we may find, according to the fluctuation of the course and symptoms, the patient is quiet and he is not that much delirious. So we will think that he is okay. That is why we have to consider what the caregiver is saying to us and what is the observation by the nurse who is frequently seeing the patient more than us. The clinical features of delirium, awareness is altered. Sometimes there is altered level of consciousness even. There is clear attention deficit. Patient will be disoriented in time, place, and person. For example, there will be memory deficit. Disorganizing thinking also is a common feature of delirium. Sometimes there may be an altered speech. Some of the patients may have hallucinations in different ways, whether visual or even auditory. Sometimes we are having delusion and even paranoid thinking. I remember one patient who had metastatic brain disease, brain tumor. She was thinking that the nurses are going to harm her by putting something in the IV fluid to kill her, which is a delusion and paranoia characterizing the delirium. Also, the patient will have sleep disturbance, especially the pattern of sleep will be changed. The patient tend to be sleeping during the day and awake and disturbing the whole environment during the night. Also, there is emotional liability. Patient may be sometimes laughing without cause or even crying without apparent cause. Sometimes there is increased agitation, or sometimes it will be, on the other hand, a decreased psychomotor activity. According to the DSM for diagnostic criteria, it is disturbance of consciousness with reduced ability to focus, sustain, or shift attention, a change in cognition or the development of perceptual disturbance that is not better accounted for by any pre-existing established or evolving dementia. The disturbance tend to develop over short period of time, sometimes hours, sometimes days, and tend to fluctuate during the course of the disease. As I mentioned before, fluctuation of the course of the disease is very characteristic of delirium. Evidence that the disturbance is caused by direct consequences of general medical condition sometimes. In the clinical presentation, we have three categories of delirium. The hyperactive delirium, in which the patient will be very agitated and difficult to control. And sometimes uh, it is in the form of hyperactive delirium, which may be mistaken for depression. and sometimes even it will pass unnoticed. The nurses will think that the patient become more quiet, become more calm, become more comfortable and very less annoying them, and they will think this is a good thing while the patient is really in delirium. And there is a mixed type, hyper and hypoactive delirium. Sometimes the patient is very agitated, sometimes he is withdrawn and hypoactive. Common causes of delirium in palliative care. Number one, we have to consider our drugs. Most of our patients are on opioids because of pain, and opioids are a very common cause of hallucination and delirium, especially if the patient develop neurotoxicity. Anticholinergic drugs like tricyclic antidepressant, which is sometimes commonly used in palliative care patients to control uh, neuropathic pain, can cause it. Anticonvulsant, sometimes our patients are on anticonvulsant because of seizures or whatever, is also a cause of delirium, and benzodiazepines as well. Infections like pneumonia, urinary tract infection, whatever source of infection, it is a very common cause of delirium, especially in elderly patients. Simple dehydration, if the patient is dehydrated, he is not taking much orally, and we didn't notice that, and we are not compensating with IV fluid, the patient will go into dehydration, and the first presentation may be simple delirium. Another common cause is metabolic and organ failure. Patient with renal failure, liver failure, hypercalcemia, hyponatremia are sometimes presenting with simple delirium. Hypoxia, if the patient is having lung metastases or chronic lung disease and he's very hypoxic, also it may alter his mental status and patient will go into delirium. Brain diseases, whether metastatic or primary brain tumor, is a very also common cause of delirium. Sometimes if the patient is not known to us having metastatic or metastasis to the brain, and he's all of a sudden developed delirium, we have to consider imaging of the brain to see if there is metastatic disease to the brain. Usually the causes of delirium are multiple, especially in the area of our palliative care patients. Because most, as I mentioned before, most patients are on opioid for pain control. Opioid neurotoxicity may be there. Dehydration may be there because of poor oral intake. Patient with metastatic bone disease may have hypercalcemia. So when you start investigating the patient, you may end up with more than one cause for delirium. In around 80% of delirium episodes, the cause may not be found, and it will be just as of unknown etiology. Also, urine retention will aggravate delirium. Constipation will aggravate delirium. So if the patient develop delirium, we have to make sure that there is no full bladder and there is urine retention. And we have to check for the bowel motion. The patient will not be constipated for some times and we didn't notice it. Sometimes in elderly patient, we have to consider dementia, of course. There are many tools used for screening and assessing delirium. The most famous one is the mini-mental state examination, confusing rate scaling, observation tools. All these can be used to screen our patient and to document that there is delirium. Now, if we go to the management of delirium, we have to approach the patient in a way, number one, to try to identify an underlying cause if possible and treat it. If the patient has infection, we have to give antibiotic. If the patient is dehydrated, we have to treat the dehydration and etc. Another important point is the treatment of symptoms. We have to control the symptoms, especially if the patient is agitated, tend to harm himself or tend to harm the surroundings or tend to pull the IV lines or whatever. We have to give him something to control his symptoms till we work up him and see what is the underlying cause and how we can manage it. The most important part again is to explain the situation to the family. This is a very, very distressing situation to the family and to the caregivers. So we have to explain to them what is going on and what we are doing to control it. So as I mentioned, number one, you have to try to control the causes as much as possible. Patient is dehydrated, consider hydration. You suspect opioid toxicity, consider to decrease the dose of the opioid. And if this is not successful, you may even go to switching the opioid to another opioid. You have to consider other drugs like what I mentioned, like tricyclic antidepressant, anticonvulsant, and to try to identify what is the offending drug and to discontinue it. Hypercalcemia, consider hydration first, and then as a second line, if the renal function is okay, we can give bisphosphonate, or an alternatively, we can give calcitonin. Patient is hypoxic, consider to give oxygen. And as I mentioned before, patient having any infection, we have to use antibiotic. We come now to the pharmacological management of the delirium itself, how I will control myself. Our gold standard here is to use haloperidol in a range of 1 to 5 milligram BID TID. If the patient is taking orally, we can give it orally. Otherwise, we can use the subcut or IV route. Other drugs which are not available here, but they are beneficial in controlling delirium is mesotrimiprazine, loxapine. Sometimes we need to use atypical neuroleptics like olanzapine in 2.5 up to 10 milligram OD BID, risperidone, and quetiapine. Benzodiazepines, really benzodiazepines is very controversial. Generally, we are trying to avoid it because in some patients it is giving a paradoxical effect and it tends to increase agitation and delirium in the patient. If we come to reversibility of delirium, 40 to 60% of cases are reversible, less reversible at the end of life. It is challenging knowing what to attempt to reverse it or just to control the symptoms. Reversal may take up to 2 to 7 days to occur. If delirium worsens or persists despite our above treatment, we have to again review the potential causes again and again and try to see what is going on. As I mentioned before, if the patient is not known to have brain metastasis before, we can consider imaging like CT scan or MRI to see if the patient developed brain metastasis. Sometimes we need to give indefinite palliative sedation if the patient is severely agitated, disturbing the environment, harming himself or whatever, or the hallucinations are severe and intractable. Sometimes we can consider simple temporary palliative sedation. When the agitation is well controlled, we can terminate it and use haloperidol again. So what I want to say as a take-home points, we have to recognize delirium, as I mentioned. It is usually unnoticed and sometimes it is underdiagnosed. So we have to have high suspicious index. And if there is any change in the mental status of our patient, we have to consider delirium. Whenever it is possible, we have to investigate and see if there is reversible cause of delirium and to manage the underlying cause and, so as we can control delirium. Uh, Again, we have to consider the family goals and the caregiver goals. We have to manage the situation in the context of the patient family. Manage both symptoms of delirium as well as the underlying cause and educate the family about delirium and this is my take home points. Thank you very much.